This presentation, titled Hospital Preparedness for COVID-19, comes to us from Dr. Rola Hammoud. Rola, as an anesthesiologist and chief medical executive at Clemenceau Medical Center in Dubai, as well as the president of the Lebanese Society for Quality and Safety in Healthcare. She's an American board certified in healthcare management from the American College of Healthcare Executives and is certified from the Harvard School of Business in the management of healthcare delivery for executives. Dr. Hammoud holds a master's degree in hospital management from the ESA Business School and University of Paris, as well as a teaching diploma and a medication diploma. In addition, she is an academic lecturer on patient safety and risk management and a reviewer for anesthesia and quality journals. Rola is a speaker on healthcare quality and accreditation and an expert on the National Committee for the Lebanese Accreditation Standards Development, as well as a training faculty for the surveyors of the Lebanese Ministry of Public Health. She founded the Lebanese Society for Quality and Safety in Healthcare in 2012 and was twice elected as its president. And with that, take it away, Rola.
Thank you, Mike. Thank you for inviting me to speak about this interesting topic today. We will be talking about hospital preparedness during COVID-19, and we will talk about what are the challenges and what did we learn from this pandemic. So, as you know, healthcare delivery is a complex system, and it operates in highly complex and unpredictable environments. The science of those systems assume that much of organizational life is uncertain and unpredictable. Hence, it cannot be standardized or cannot be controlled. Those are the hospitals where we live on a daily basis. And the COVID-19 pandemic was a powerful reminder to us that we are living in highly complex systems and unpredictable world. In our talk today, we will go through all systems needed to ensure a proper planning, a proper implementation, and a proper monitoring of a crisis such as a pandemic. We will talk about the environmental management systems, the quality management systems, how to integrate all those systems to ensure a safe environment for patients, a safe environment for our staff, and how to use new technology and to monitor that we're doing the correct thing. So much of hospital organizational life is uncertain and thus cannot be standardized. The COVID-19 pandemic has created a multitude of acute challenges for healthcare organizations, including inadequate capacity, supply shortages, the need to redesign our care, to adjust the workforce, and to cope with our financial losses. Effective responses to the pandemic have required departures from many conventional practices and adoption of new techniques like the telehealth. An effective COVID-19 hospital preparedness plan would have to incorporate information from the national authorities, from governments, from associations, as we did during this pandemic, like the CDC or the WHO, who were continuously feeding globally all healthcare systems with the needed information. And of course, there at the level of the countries, there was like national command centers. We had one in Lebanon and one in UAE. So just to control protocols, and we will be talking about the protocols at a later stage. So planning for a community outbreak is critical to maintain the healthcare services during a response. And the CDC has developed a checklist to help hospitals and all acute care facilities to assess and improve their preparedness to this response. And today we will be talking about the elements of this checklist because we find it very informative and needed for the practices, for safe practices during crisis in hospitals. So those plans that we need to ensure at the level of a hospital would need to also comply with the local regulations and the standards of accreditation and the best practices in medicine. The objectives of planning for and to be prepared is to really prevent spread of the COVID-19 within an organization. It's to promptly identify and isolate patients with possible COVID-19 and inform the correct facility staff and the authorities about those patients. It's to care for those patients, and of course there will be protocols implemented for the management, to care for a larger number of patients in the context of an escalating outbreak, and to monitor and manage healthcare personnel that might be exposed to COVID-19 while communicating effectively within the organization internally and externally with all related authorities and other community hospitals or centers that we need to connect with. The first step of this planning is to structure structure the plan and the decision making. This is why we create a multidisciplinary planning committee, which is a team created to address COVID-19 preparedness. It's a staff, then we assign staff to us to be responsible to coordinate this preparedness. We have to assign a coordinator for this, and of course he will be backed up by the planning committee members. And then we have to have contacts with local or regional planning groups to exchange ideas, to get more support, to have more insight about what's happening in other facilities. The facility leadership should review the CDC's COVID-19 guidance and the WHO recommendations. And of course, the planning committee should be structured and should have members in it to help the plan to be implemented. The planning committee can have up to 10 to 15 members. The list of those members should be available for all hospital staff. The members should be part of the hospital administration, the legal, the risk management, infection control, disaster coordinator, public relation coordinators, medical staff, including emergency medicine, infectious disease, pediatrics, nursing administration, human resources, occupational health, intensivist, and engineering and maintenance, very important to maintain the environment where we're working at. The second stage would be developing a written COVID-19 plan, which was done by many hospitals during this pandemic. And it is recommended by the WHO checklist to have this. Actually, it's not about only COVID-19. All hospitals should be prepared to any type of crisis, and those steps can help also in the preparedness for any other type of crisis. So the plan, the written plan, is very important. This plan should be accessible to all staff, and there should be authorized persons to implement the plan, of course, with the help of the committee. The organizational structure and the delegation of authority to carry out this plan should be clear, and it is part of the checklist to have on board people responsible and accountable at the same time. Implementing specific actions based on the authorities' recommendations, whether national or international. Assigning key responsible people and key responsible department is also something to work on within the facility. It is related to executing the plan and to describing the personnel who will be serving as a backup in case we have failure or in case we need more support. Those personnel need to be also trained on response objectives, priorities, and on policies. The third step is to identify what are the elements of this disaster plan or the COVID-19 plan. Basically to monitor all public health advisories, update the response coordinators with all new protocols, monitor the developments of the disease, and monitor the number of staff who is unable to report to work because of the disease in order to assess our human resources and task force. Written protocols to identify, monitor, and report COVID-19 as well. A plan to track COVID-19 related staff sick leaves, a protocol for evaluating and diagnosing hospitalized patients, staff with symptoms of COVID-19. There should be also a protocol to manage people with possible COVID-19, I mean the medical management, and a system to monitor for healthcare-associated transmission of COVID-19 in the sense of how to control the infection and how to prevent it from being an outspread in the environment, in the organization. For this, we have to tackle different aspects. First is the facility communication. And by communication is important, and communication is the main element that is responsible of many adverse events in the healthcare setup. This is why we stress on how important it is to be performed on time, to be performed correctly, and not to have missing information. There should be a protocol for internal communication and external communication. So there will be a person assigned for the internal communication with the staff, with the patients, with the families. There should be only one voice speaking up inside the facility to inform about the outbreak, to inform about the spread, and to give accurate information. The other part of the internal communication is communicating with patients and with their families. Also, this is important. We have also to take into consideration the degree of stress of those people and to be empathetic. And it's very hard during the crisis to have also to tackle also this element, because everyone is under stress, and even the healthcare providers are under stress to not to attract the disease themselves. So there are tools and materials for this, and those tools like using signs, like using phones and other methods of communication are used to inform the staff and family members and visitors also about the current status of the disease and what are the future plans. For the external communication, we should assign also a person to communicate with the authorities and who can obtain information. This person should be developing brochures, should be developing materials. This material should be language and reading level appropriate for our patients, for our staff, and a plan should be in place to disseminate these materials in advance, specifically also to the external parties like other health hospitals in the community with whom we want to collaborate to transfer patients, or whom we want to receive patients from, any other emergency services. And a hospital representative should be also involved in discussing those local plans for inter-facility communication during an outbreak. Very important to keep the communication with the external parties. Another aspect is the medical supplies shortage, which should be addressed also at the level of the hospital management. So we have to be on top of the estimation of what quantities are essential for patient care materials and equipment, and what PPE, personal protective equipment, is needed, like face masks, like goggles, like gowns, like also respirators, ventilators for the equipment. All this we have to estimate our need, and I think a backup of an 8-week outbreak is only logical. The plan should be developed to address supply shortages, and to see what are the alternative channels, from where shall we bring in case of any shortages, and how to conserve our PPEs. Also, many hospitals worked on conserving their PPEs in different strategies. So we have to prioritize our needs, we allocate our needs, and we look at the patient care equipment, at the pharmaceuticals, the medications needed, all resources needed for us to ensure a supply for an adequate period of time. So also the facility should provide the supplies and materials on time to its staff. And we also mentioned the PPEs, but we have also the alcohol-based hand sanitizers, which should be available for the staff to avoid the spread of the infection. Things are in the hospital should be well stocked with water, soap, and paper towels. We have to have the signs dispatched all over to encourage people for social distancing and for hand hygiene. The trash disposable bins should be placed at the exit of each room to be used, and the use of hospital-grade disinfectants during the pandemic to clean between patients is also a high recommendation. So basically, there should be a contingency plan that the facility has to include all departments, the need of the departments, their experience, and what happens in case of supply shortages. Regarding the care for patients, also we need to have our protocols. We have to have the identification of patients, how to decide that this is a COVID-19 case, the triage process. We've done lots of face-to-face triage, and we've done also, we learned how to do the teleconsultation, the phone triaging, how to advise people to stay at home, and when to advise them to come to the hospital, and decide to know we really need to assess them face-to-face and to advise them on the treatment, or to admit them to the hospital and initiate the monitoring and the treatment. So triage areas, signage, and equipment is very important in the emergency rooms of the hospitals, and having a separate triage area is highly recommended, just to avoid the contact with other type of patients and to stop spreading the disease, of course, while maintaining the social distancing. Training personnel is very important, and the training should be continuous. Because the protocols are changing on a daily basis, training should be done really not on a daily basis, but on a weekly basis to all personnel who are dealing with the disease and who are dealing with triaging those patients and who are managing those patients. The admission criteria should be very clear because we do not want to admit all patients and have shortage in hospital beds for the community. So we have really to set a clear criteria for a treatment at home, which we did a lot during the pandemic, while contacting patients every day and asking about them and asking them to measure their saturation and telling them when is the critical point to come to the hospital. And there should be criteria for admissions, and even those criteria are divided into mild, moderate, severe, and critical to assess where to admit those patients on a regular floor or in the intensive care unit. Transporting patients within the hospital is an important element to be addressed because we need to create a special path for those patients. This path should be cleaned every time we have a patient going inside the hospital. Some hospitals did split their buildings into two buildings, one COVID and one non-COVID. Very good for the hospitals who can do it this way. Transporting patients to outside facilities also is something that we need to think about how to do it, whom to go with those patients, to accompany the patient, what PPEs are needed. All this need to be addressed in the preparedness plan. And of course, notifying the management and the authorities is also done on a continuous basis. Just not to miss any information and to be on top of all new elements. The visitor access should be identified also. We have to review the plans for the visitor access, how many visitors per patient, do we really want visitors to come to the hospital? How do they move within the facility? How to track them? Developing materials and posting signs to instruct those visitors not to visit if they have fever, symptoms, or any respiratory infection is also important. How to triage those at the entrance of the hospital and to ask them to go back home in case they have any symptoms and to follow them by phone afterwards. Video call, cell phones, tablets were the remote communication used during the pandemic, and those really were very effective. Also, we have to advise visitors what PPEs to use. We have to instruct them on hand hygiene, on maintaining a record of all visitors who enter and exit the hospital, and ensure their movement within the facility. Occupational health is very important to think of because we have to protect our staff. We have to think about them because we want them to stay healthy in order to care for our patients. There should be a registry of the sick leave of all staff, a very clear policy on this employee sick leave. That is in alignment with the public health authorities' policies and the national policies. All staff will be instructed about this policy. And when I say staff, it includes also contractors or volunteers or people coming outsourced staff and students if there are any academic activities. The process to conduct symptom and temperature checks prior to the start of any shift was done in many facilities, and it is recommended by the CDC's checklist to be performed. The process to identify those staff and to advise them or to treat them also is important, and to monitor the work restrictions for those ill staff. Of course, auditing the adherence to the recommended PPE use by the healthcare professionals is also something that needs to be done on a daily basis by the hospital quality team to ensure that everyone is, and the infection control officers, to ensure that everyone is abiding by those guidelines. And at the end, the occupational health need to ensure vaccination of all staff to decrease their exposure and to have them safe while treating COVID patients. Education and training is important as it is during our normal days. It is more important during crisis days. So educating our patients, their families, training our staff on all what we spoke about, on the protocols, on the PPEs use, on the hand hygiene, on social distancing, is very important. And there are many tools and educational material for those patients and for the staff available, and the hospital should have those available also to be consulted at any time and to be revised and reinforced at all time. Signs should be posted, and it's very important to maintain the infection control measures and reinforce infection control practices. The surge capacity plan is a plan that includes strategies to maintain the hospital's core missions and to continue to care for patients with chronic diseases as well as COVID. So we don't need to forget that a hospital caters for all types of diseases. It's not only COVID, and we have to maintain our population of dialysis patients, cancer patients, all patients who are critical and vulnerable population. We need to ensure they are safe. We need to ensure that the COVID does not transmit to those patients. And for those, we should put our plan to help. We have to have in this plan to help and increase the hospital bed capacity. We have to help in ensuring staff coverage and ensuring also the other supplies. The plan should include the strategies to use in emergency department to mitigate and accommodate additional patients and mitigate other risks. So perhaps having different triage sites, performing more of a telemedicine, and having call centers are answering patients' queries is something that we want to implement for those patients. Also, we can have signed agreements with established with other hospitals for long-term care facilities, and to help us really transfer those patients whenever we need. This is only a framework that outlines an approach. It's from the Health Catalyst system. Any hospital can really put its own framework that tackle how we prepare, how we prevent, how we recover, and how we plan for the future. And this framework takes into consideration the infrastructure, what we have, and this is where engineering and facility management have to help a lot. They have controls to do on a daily basis regarding the pressures of the rooms where we are keeping our patients, regarding the safety of the environment they are in. We have to tackle our clinical improvement and the patient safety. This is and a very important element on this framework. Patient safety officers and the risk management officers will have to continue their work and will have to increase the work they do to monitor the implementation of the clinical protocols set by the physicians. Of course, the operational aspect will continue, would have to have also all the planification very clear for everyone. And not to forget the financial impact, and the finance should be on top and be prepared to cut cost wherever it is needed, and to provide support for the areas in need, like providing continuously the PPEs for our staff. So each hospital, if they have such a framework, it's very useful for them and for the staff at the hospital to follow this. So as we see, we consider all kinds of risks, and we are implementing during the crisis the plan, do, study, act cycle of the quality management. We identify our risks. We have people to think about how to mitigate those risks, and how to put a plan for business continuity, and how to act on this plan, and how to measure it and take more actions after we decide and after we study our measurements. Of course, always we have to consider our reputation. We and as Albert Einstein said, learn from yesterday, live for today, and hope for tomorrow is something that we do continuously during a crisis. We are creative in our approach to move forward. We listen to what our stakeholders want and to what they need, and we help support in implementing what their needs. Auditing and evaluating is something to be done continuously. There should be audit for the planning, auditing for the operation, how we are implementing, and also reporting is very important during a crisis. The reporting should be done by either physicians, by nurses, healthcare providers, or by families, by patients, and this information is taken very importantly by the risk management of the hospital in order to act, and the action should be very quick and very prompt to continue having safe environment and safe practices for our patients. Having all those elements in a proper, clear checklist help each organization to audit their preparedness. And I advise all organizations to have this checklist present, and to discuss it with the risk management committee of the hospital, and to consult this checklist on a regular basis in order not to miss any element. All the elements that we talk about are very important. If we have them all, we are sure that we are ready to tackle any new crisis or any new pandemic. Thank you very much for listening, and back to you, Mike.
Well, thank you, Dr. Rola Hammoud, for that look at hospital preparedness for COVID-19. And that concludes this presentation.